Welcome, everyone, and thank you for joining me for another episode of MASH Masters, the ABCs of Non-Invasive Tests, or NITs. I'm your moderator, Dr. Naim Alkhouri, the Chief Academic Officer at Summit Clinical Research, and I am joined today by my dear friend, Dr. Sonal Kumar, who is professor at Weill Cornell Medical College. She is the Director of General Gastroenterology and Hepatology, and she is someone who contributed significantly to the field in terms of bringing the multidisciplinary approach to managing MASLD and MASH, and she directs the iChange clinic. Welcome, Dr. Kumar, and thank you for joining me.
Thank you for having me. Good to see you.
So we're going to discuss the ABCs of non-invasive tests, and I want to take your perspective as a hepatologist. How do you think about non-invasive tests, and how do you utilize them in the hepatology clinic? So can you give us an overview of non-invasive tests that we utilize to determine the severity of MASH?
Yeah, I think, non-invasive tests are such a huge, important tool that we have available to assess fibrosis in our patients and determining who really is at high risk for disease progression or having advanced disease, which we know is an important predictor of outcomes, all-cause mortality, et cetera. So I like to classify the non-invasive tests sort of into three buckets. They're the serologic tests that are simple scores. These are things like the FIB-4 index, for example, is probably what we see the most often in care pathways and algorithms and in the literature. And these are tests that use everyday labs, AST, ALT, patient characteristics to determine the risk of having advanced fibrosis or not, or ruling out advanced fibrosis. So these are really easy tests to do with everyday blood tests that you're checking in your patients. Then we have the proprietary predictive scores, also blood tests, but these are send out tests, or these are not tests that you can actually calculate in the clinic. And these are more predictive scores. So, what is the risk of progression, risk of developing cirrhosis in our patients? And the ELF score is probably the most common one that we see. And then finally, there are imaging-based modalities. So elastography is sort of the technology that's used in these imaging modalities. Vibration-controlled transient elastography, or FibroScan, is often used as a point-of-care test in many clinics. Shear-wave elastography, MR elastography, if providers have that available to them, is a good tool to assess fibrosis. And those give you measurements of not only steatosis, but also fibrosis.
Well, thank you for this excellent overview. So you started by mentioning these simple scores, and we've discussed the FIB-4 index in previous episodes. Clearly, it's easy to calculate, but if it was enough by itself, we wouldn't need the more sophisticated technologies. So can you highlight some of the limitations of the FIB-4 index?
Yeah, I mean, you'll see the FIB-4 score, as you mentioned. It's a really easy test. It just requires four parameters: AST, ALT, age, and platelets. And I think it's a really good screening tool for providers to use sort of in the non-GI, non-hepatology practices where you have large numbers of patients that you just want to screen to see if they need further testing, or if to rule out the risk of having advanced fibrosis. But it does have its limitations. I think one of the important ones to recognize is type 2 diabetes. So this is a very at-risk population. Diabetes has been identified as the strongest predictor of disease progression in patients. So you have to just be a little bit careful in using the FIB-4 score in patients with diabetes. They can have a normal FIB-4 score, but still have fast disease progression. So these are the patients that I like to use other modalities for assessing fibrosis. And then also, because the FIB-4 score takes into account age as part of the calculation, patients with older age are going to have naturally a higher FIB-4 score. So to try and counteract that, we do have different cutoffs for patients over the age of 65. Normally, we use 1.3 as the lower end to rule out advanced fibrosis. We use 2.0 in patients who are over, or who are 65 years or older. And then similarly, because platelets are in the calculation for the FIB-4 score, patients who have low platelets from other etiologies will have can have an elevated FIB-4 score. And then alcohol intake. So alcohol patients who consume alcohol will have a sort of shifted ratio in their AST and ALT. So they'll often have a higher AST to ALT ratio, and that also is in the FIB-4 calculation. So you can get a higher FIB-4 score in patients who have high alcohol intake.
Well, thank you for highlighting these limitations. And of course, this highlights the need for other NITs. So, as a hepatologist, what are the other non invasive tests you use in your clinic and how do you interpret them?
Yeah, so I think, as I mentioned, the FIB-4 score is nice, simple score. These simple scores are nice for non-GI and non-hepatology practices, but once a patient gets to my clinic, I really want to use a little more comprehensive testing to get a little more accuracy in terms of how much fibrosis they have. So we mentioned the different imaging-based technologies that we have on the first slide or in the early in the discussion. I personally use transient elastography a lot. I always tell providers use what you have available because all of these tests are pretty good. This is a study that looked at almost 400 patients who underwent paired liver biopsy and transient elastography. And you can see these are the different cutoffs that were identified and their relative sensitivity and specificity, negative predictive value, positive predictive value. And you can see the cut points for F2 fibrosis, F3 fibrosis, and cirrhosis. Now transient elastography also gives us measurements of steatosis in addition to fibrosis, and a CAP score of greater than 275 has been identified as being consistent with having significant steatosis. And then there's MRI. So the MRI probably has the best negative predictive value and the better sensitivity and specificity than transient elastography or FibroScan. It's not always easy to get. You have to consider the patient as well. A lot of them are claustrophobic and don't want to get it, but it is a good test and it is a good tool if you have a patient that's willing to do it and access to it. The MRI also gives assessment of steatosis through proton density fat fraction, and then MRE or MR elastography is helpful in assessing fibrosis. But what about combining some of these tests? So, we have different imaging based modalities, we have some simple scores, we have some lab parameters. So, people have studied looking at other scoring systems to determine who is at risk. So, not only just ruling in or ruling out advanced fibrosis, but really honing in on who is at high risk for disease progression. So the FAST score is a nice, easy one that I like to use. This takes into account not only the fibrosis marker, the kilopascals from transient elastography, but also the CAP score to sort of score the steatosis, and then AST as an inflammatory activity marker. Now, this is not obviously, you can see the calculation on the bottom. It's not an easy test that you can calculate on your calculator, but there are online calculators that make this really easy to do. You just input the lab values and it gives you a score.
And I want to highlight that you can download an app called My FibroScan app, and this will allow you to calculate the FAST score and other scores that utilize transient elastography.
Yep, absolutely. And here you can see the negative predictive value using the FAST score is 0.95 compared pooled, and that was in US screening compared to pooled externals 0.94. So really good test to help identify patients who are at risk. And similarly, using MRI, you can do the mass score, which is MRI and AST. And here you can see the different parameters that you enter, similar to the FAST score, except the MRI values. You put in the kilopascal value, the percent fat fraction, the AST, and the FIB-4.
And I utilize this website called coulditbemash.org, and it can help you with these calculations that utilize MR elastography and PDFF. And as you mentioned, the mass score is similar to FAST, but we rely on PDFF, which is a more accurate measure of steatosis, MR elastography for fibrosis, and AST for activity. So, Dr. Kumar, these are very useful tests, and as you said, availability is probably the biggest limiting factor. Have they been incorporated in guidelines? Can we provide the audience with some background on how to utilize them in terms of cut points also?
Yes, absolutely. I think what's been nice over the last couple of years is that we've had um, some direction from our societies on how we should be utilizing these tests. And so in 2023, the ASLD put out some guidance on how to identify, again, this at risk MASH population. And so in this document, they have different cut points for FAST score and the MAS score. So if you input these values either onto your app or onto the website, you'll get a value and you can just see the different cut points there. We didn't talk about the MeFib score, but that's taking into account MRE elastography and the FIB4 score, another just test to help identify that at-risk population. But there are these cut points within our guidelines now that help us decide what we should be doing with these patients or how we should be considering them.
So, in the previous episodes, we discussed the primary care algorithm, but we also have the hepatology algorithm. So, I think this is what you see in this slide from the ASLD 2023 guidance document. A little bit complex, but I think we need to highlight that, we start screening in primary care and endocrine clinics. Once you identify patients that might be at risk for having advanced disease, you need to increase your positive predictive value. And this is when we utilize these tests. You have any comments on this algorithm from ASLD?
Yeah, I mean, this is nice to have this out there because, there are you talked about the primary care algorithm, but there's also now an algorithm for us and how we should be using this in GI and hepatology care. And it really helps sort of streamline our patients.
Yeah, it's really refreshing to see all these technologies. Clearly, we could not cover every test, so apologies for any manufacturer if they didn't hear about their test. But we have several serologic tests that we utilize in our clinics, including the liver fast and the owl liver. We also have other MR-based technologies such as corrected T1, other ultrasound-based technologies beside VCTE, such as the hepatoscope and Velicure and shear wave elastography. And I think the message is positive for our patients. I always say if you are told you have fatty liver disease or steatotic liver disease, you need to ask your provider what is the stage, and you do not need a liver biopsy to know the stage. It can be done very simply with a blood test or an imaging test. Well, thank you so much, Dr. Kumar, for joining us. This was a great overview of the NITs for the specialist. And for the audience, if you are interested in learning more about MASH and new advances in non-invasive tests and new treatments, please join the website listed here and visit the MASH Clinical Advances page provided by Medscape. Thank you for your attention.
Thank you.
Welcome.